Good afternoon, and welcome to the HL7 Da Vinci Community Roundtable. Today's session, Prior Authorization, Are You Ready for 2027? My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate information sharing and collaboration. Today's session focuses on prior authorization, also referred to as the burden reduction IGs. The goal of today's webinar is to provide an insightful, holistic discussion targeting those who want to better understand how best to meet prior authorization regulatory requirements, aiming to increase efficiency and improve patient outcomes. With a focus on the latest developments surrounding prior authorization implementation guides, or IGs, the session begins with an examination of clinical and business drivers and a level-setting overview of federal and state activities impacting prior authorization requirements. Then we'll highlight technical standards focused on the underlying requirements of CMS's 0057 final rule, HTI-4, and current status of the implementation guides. This session concludes with how Da Vinci responds to industry needs, fostering a supportive environment for implementation and providing education, resources, and learnings from real-world implementers and piloting opportunities for those on the implementation journey. Our esteemed panel today brings you subject matter experts from across the continuum. Lloyd McKenzie from HL7 Da Vinci's team is a deputy technical director, as well as the chief of the chief standards officer at Dogwood Health Consulting. Dr. Viet Nguyen is HL7's project technical director and HL7 chief standards implementation officer. Denise St. Clair is also on the Da Vinci Project PMO and is Vice President, Health Policy and Interoperability at Global Alliant. Dr. Steve Waldron is co-chair of HL7's Da Vinci Clinical Advisory Council, as well as the Chief Medical Informatics Officer at American Academy of Family Physicians. Let's go ahead and give you some housekeeping and some program updates before we transition to our panelists. We have muted all the lines to aid the recording quality for today's webinar. We will be posting the webinar and the slides. Should you have questions, please use the Q&A feature to submit those questions, as we have disabled the chat. At the end of the webinar, or when you leave, a survey will be launched, and we really hope that you will complete that, as it really helps us with future programming. Our community roundtable schedule continues to be the fourth Wednesday of each month, with our next event September 24th at 4 p.m. Eastern. You'll see the registration details posted to the Da Vinci calendar when they're available, and you'll also be able to access the recording and the slides from today via the Da Vinci calendar during the video on the video presentations page. As to upcoming events, there are a couple that we'd like to tout. First and foremost, there's a 39th annual plenary and working group meeting and HL7 Fire Connect-a-thon, September 13th through the 19th in Pittsburgh, Pennsylvania. We really hope you'll be able to join us at that event, which also has some hybrid capabilities that you want to check out. From a broader industry perspective, NCQA's Health Innovation Summit will be held October 13th through the 15th in San Diego, and WEDI's 2025 National Conference will be November 3rd through the 6th in Washington, D.C., and often provides hybrid access as well. The Da Vinci community is really working very closely with industry to advance piloting efforts, in addition to our overall testing experiences through our Connect-a-thons, which, if you don't know about those, you'll learn more from our panelists in a little bit. For those of you who've been tracking with the Da Vinci Project for a while, you're probably familiar with the fact that we have the Da Vinci Project Trebuchet and the patient cost transparency pilots underway. From the Trebuchet side of the house, their next public call is tomorrow at 2 p.m. Eastern. Well, they'll be focused on TEFCA, CMS Aligned Networks, CMS 0057 compliance overview. They have regular Thursday calls every other week from 2 to 3. Encourage you to check out tomorrow's webinar as well as access their pilot information and call details at the link provided. And also consider signing up for a pilot cohort that'll bring trading partners together in a supported community to advance their piloting and pre-production efforts. On the patient cost transparency side of the house, or PCT as we call it in shorthand, their next meeting is September 8th, and they meet at noon Eastern. Everyone is welcome, and they've been well underway, and so you'd be joining to learn about their efforts that are furthering the CMS's July Connectathon testing event, where they successfully submitted and received good faith estimates, or GFEs, with the reference implementation software code that's available, and they were able to show the results to a patient through that demonstration testing effort. Their next milestone for the PCT pilots is coming up shortly with the September HL7 Connectathon, with other participants submitting and receiving PCT conformant good faith estimate packets. This is a part of the continuum that they're advancing under the PCT body of work, starting with good faith estimates and then working towards advanced explanation of benefit related piloting. Encourage you to reach out if you're interested in joining that community that is really underscoring FHIR-based capabilities tied to the No Surprises Act and providing more visibility for patients into potential liabilities from schedulable services. Da Vinci will also be at the HL7 39th Annual Plenary and Working Group meeting. This also includes the Connectathon work over the weekend, where we'll have tracks for burden reduction or the prior authorization suite you'll be learning about more today, patient cost transparency, as well as payer data exchange and risk adjustment. We have specific sections of Confluence where you can find out more details about Da Vinci's presence at the Connectathon, as well as where we'll be participating or holding discussions during the week of the working group meeting, Monday through Friday. There is a new fact sheet from HL7 if you're curious to learn more about the Pittsburgh HL7 Working Group meeting. This is a very recently available materials, so we've provided a link to the factoid sheet that HL7 has developed. It can help you, especially if you're a newcomer. Additionally, HL7 Policy Advisory Council or Committee, excuse me, or the PAC, will be holding sessions related to global and U.S. federal policy conversations. That's an atypical activity, and I think in particular, the U.S. federal sessions on Wednesday may be of interest to folks. Those will be happening Wednesday, Q3 and Q4 in the afternoon. And you can learn more about those details by checking out the working group meeting agenda. Without further ado, I'd like to invite Dr. Steve Waldron on to come on camera, and I'll turn it over to you, Steve, to set the stage for us on patient and clinical drivers.
Thanks, Alex. Appreciate it. It's a pleasure to be here today. I thought too, I might, before I get into my remarks, kind of take advantage of my position here to be able to say thank you to everybody in Da Vinci and all the members, the volunteers that are working on standards from the developers community and from the payer community and from a lot of provider organizations that are part of the Da Vinci project. And on behalf of the 70-some thousand family docs that I help try to drive the better primary experience for them and their patients. We just want to thank you for doing this heavy work. We know it's a lot of work. Of course, we'd love to have it finished today, but understand why it's not. But just wanted to thank you before I get started. But I think sometimes when we get into the standards world and we kind of start to think about all the technical issues, all the clinical informatics issues, the data modeling issues, the little bit about kind of how the workflow and how things go into it, and we can easily get pulled into that. And I'm even guilty of that, having kind of tendencies toward, geeking out and being a nerd. And I think sometimes we kind of forget, or at least kind of take our eye a little bit off of what are we really trying to get accomplished at the highest level here? And we thought we'd want to spend just a few minutes just to kind of level set on that and bring that into focus before we get into a lot more of the technical aspects of our panel today. So I wanted to talk a little bit from that patient and clinician side. And as I have the two hats here, I'm mostly going to be talking about it from my AAFP hat and the docs that I talk to almost every day, talking about some of their challenges. And I'll talk about the CAC in a little bit later in the presentation. But almost every time I have a conversation with a member of ours, no matter what the original question or issue was, two things always come up: AI and prior authorization. And our docs are really frustrated with how the current system just doesn't work. It's not saying that there's not been some improvements in that process. A lot of the payers spend a fair amount of resources creating portals to make it easier for docs. But in family medicine, the majority of our docs see 7 to 10 patients that have at least 7 to 10 different payers, and many over 14 different payers they work with. So even if every portal had a very similar workflow, same data requirements, same approval processes, you still have 7 to 14 portals you're going to have to log into and remember what the URLs were and which one goes with patient. And then you got to move patient contacts data over into the portal. So, if you only had 1 or 2 of those portals, it may not be that big of a burden. When you have 7 to 10, even that's just a huge burden. So how do we kind of harmonize this together? And that's what I think is some of the great things that are happening inside these Da Vinci IGs, is to be able to create a common exchange process between providers and payers to address some issues. The other thing that I hear from our docs is, we talk about use cases, but I think about a couple of different scenarios around prior auth. And the two that I hear the most challenging for our docs, one is more, it's just because it frustrates them. And that's where things that seem like, well, this is a duh. Why are we doing this prior auth? So for an example, for a patient that's on diabetic meds or getting diabetic DME related activities, or a standard referral back to the endocrinologist that they've been seeing for the last 4 years. We all know that diabetes, unfortunately, is not curable yet. So why every year or 18 months do I have to go through the same process of doing the prior auth for the same stuff that I just did for this patient multiple times? Or is this a simple generic too that's like, well, why are we doing this? So I think in those cases, we have the ability to automate that quite significantly with some of these standards and further work on the EMR and the payer information systems work to eliminate those. So hopefully docs would not even see those. The other scenario, though, requires the doc to be in the loop. And that's where you have the real clinical data that needs to be provided as part of the prior auth process. So how can we do that in real time? Because my docs talk about, well, I saw this patient and nobody told me that it needed to have a prior auth. They got to the pharmacy, got to notice that they had to have a prior auth, comes back to me. So I go and look it up, find it. Well, now I have to ask a couple more questions to the patient. So do I bring them back into my office and incur another office visit for the payer to pay for, inconvenience for the patient, time off of a schedule for a very busy primary care doc? And it runs into just a lot of challenges. So we need to be able to support these kind of exchanges that are real time and have that clinical component. And I realize, as being an informaticist, that means that's going to require a fair amount of work also, though, on both sides of this interoperability that are not necessarily in the IG. So how do you do some of that triage work in the EMR to kind of eloquently go between who in the back office might need to fill out some information and what data needs to go right to the clinician and which goes first and those type of things. So again, we appreciate that this is a really complex problem, but I think we have to remember that the ultimate goal here is really to get the most cost and clinical effective treatment for patients as fast as we can with as little burden on the providers, patients, and payers for that matter. And we need to make sure that our standards are really doing that, and make sure that we're testing them and saying, does it really meet that? Because again, like I said, I think there's probably some additional kind of functionality that developers on both sides of the exchange are going to have to build over this amount of time. So that's kind of what I want to make sure is that we kind of keep looking at the forest every once in a while as we're down, working diligently in the trees. And I appreciate all the work that everybody's doing. So let me stop there. Let me hand it over to our colleague Denise Sinclair from the PMO office, and let her talk about it kind of from that business drivers and regulatory landscape on kind of why are we try to do this. So Denise, take it away, please.
Thank you, Stephen, and hello, everyone. Thank you, everybody. So we are witnessing this sort of phenomenal momentum toward leveraging digital technologies to improve all aspects of healthcare and specifically prior authorization. And we're seeing an increasing focus on FHIR. And so this is just a really exciting time for those of us who are the geeks who've been engaged in these standards for some time to see things really picking up. And this is such a wonderful opportunity for all of us to be the leading edge in that process. But this is really based on a real push coming from all the way at the top, and then some real solid requirements from the regulatory space. But then there's also some real business drivers and values for all the patients, providers, and payers engaged in the process. So we'll just take a few minutes and kind of work through all of that. So what's been going on very, very recently? Well, very, very recently, at the end of June, Health and Human Services convened payers from across the healthcare spectrum, and they received pledges from some of the biggest payers to reform the prior authorization process. And so this included a commitment to standardize electronic submissions for prior authorization via a FHIR-based API. And so that was the prior authorization pledge. Then at the end of July, the White House convened a group of over 60 leading healthcare and tech organizations to lay the groundwork for a truly patient-centric digital health ecosystem. And so you've had sort of these two big moments, very public, sort of saying, hey, we are all committed to using FHIR, to using digital technologies, to pushing the tools we have available to us to make healthcare better and to ultimately make patient care better and the patient experience better. And so all this is building off of some of the seminal CMS interoperability regulations that started with the interoperability and patient access final rule, and specific to our discussion today, as we'll see on the next slide, the interoperability and prior authorization final rule. So as we affectionately refer to it, 0057 was, among other things, a final rule that required what is referred to as the prior authorization API, or application programming interface. And what this did was require that APIs must be made available, and that ultimately an API must provide a list of covered items and services, identify documentation requirements for prior authorization approval, and support a prior authorization request and response. And as we know, the CMS regulations at this time do not require specific implementation guides, but what they do is strongly recommend the use of certain implementation guides. And of course, it was the three Vinci burden reduction IGs, coverage requirements discovery, CRD, documentation templates and rules, DTR, and prior authorization support, or PAS, that were specifically called out. And ultimately, what this rule really did was say for those payers who are regulated by the Centers for Medicare and Medicaid Services, so this is Medicare Advantage, Medicaid, and CHIP fee-for-service and managed care, and the plans on the federal exchanges, need to, among other things, be prepared to leverage prior authorization APIs. And there were also some additional, not specific FHIR rules, but that really are supported by leveraging FHIR APIs, like decision time frames. So reducing urgent decision times to 72 hours, non-urgent decisions to 7 calendar days, making sure that there is provider notice, including a clear denial reason if a prior authorization is denied. And then there was also public reporting of prior authorization metrics that were required. And the metrics, the primary metrics, are indicated here on the slide, and we'll talk more about metrics in a moment. But ultimately, from a regulatory perspective, the requirements are that payers be able to report publicly the percentage of prior authorization requests that were approved, denied, and or approved after appeal, the percentage of prior authorization requests for which the review timeframe was extended or subsequently approved, and the average and median timeframes between submission and decision for both standard and expedited prior authorization requests. And ultimately, this is a way of showing that we are ultimately going to be able to baseline and then see in the future that we are improving that time that a prior authorization takes by moving to a digital approach. And so we really then had this sort of base requirements for how we should move forward related to FHIR-based APIs and prior authorization. Well, we were also then further gifted some really strong signals about where the federal regulatory landscape is going in terms of FHIR and specifically prior authorization quite recently. So on the next slide, we have some links and some information about the very newly finalized Health Data Technology and Interoperability, Electronic Prescribing, Real-Time Prescription Benefit, and Electronic Prior Authorization Final Rule, which is much easier to refer to as HTI-4. So this is finalizing some but not all of the requirements of the proposed HTI-2 rule, but very pertinent to our discussion today and our work in Da Vinci is that the final rule presents 3 new health IT certification criteria related to electronic prior authorization, specifically leveraging the HL7 Da Vinci IGs. So again, we see that we have a provider prior authorization API, CRD, DTR, and PAS certification requirement. And these are all based very much on the 0057 rule requirements. And so we're seeing this progression in a very logical way. Now, of course, this is all voluntary at this time, but once there are certification requirements available, that opens up the opportunity for those to become part of other programs, such as CMS programs. And this does support the providers who are participating in the Medicare Promoting Interoperability Program and the MIPS Promoting Interoperability Performance category. There are some electronic prior authorization measures starting in 2027 that will be facilitated by these certification criteria. So we have this very, very clear signal and this strong regulatory framework for leveraging the Da Vinci prior authorization IGs to support FHIR-based APIs to support prior authorization. So it's really important to kind of look at it within the landscape of these regulations that are really building one on the other. But there's another piece here that's really important not to forget, and that's the role of the states. So while the federal landscape has been further laying out a structure for us from a regulatory perspective, the states have been hard at work on prior authorization initiatives as well. And there's many more than this, but we're highlighting just a few here to give you an idea of how these federal regulations are very much in line with what the states are doing. And in many ways, the states are taking it a step further. So, Minnesota by January 1, 2027, they are requiring implementation and maintenance of prior authorization APIs in accordance with the federal regulations. Colorado, also in 2027, is requiring that data on prior authorization requests be made publicly available, again, consistent with the federal regulations. Illinois has the Prior Authorization Reform Act, And that's been in place for some time and is requiring payers to publicly disclose their requirements and provide detailed information for each service and to really have that transparency. Again, very familiar with and in line with the federal requirements. Louisiana also has a law in place to mandate that payers report specific prior authorization metrics, and that they really work toward those expedited requests and being transparent about that. So we're seeing this real consistency and this growing landscape of regulatory foundations at both the federal and state level, which really helps kind of lay the groundwork for the work that we're doing. So that's what we have to do from a federal and state perspective. But we just want to take a second and talk a little bit about why we might want to do this and the value. So from a regulatory perspective, we see that there can be benefits to patients, providers, and payers. And this is definitely what the regulators were focusing on when they brought this forward. You know, for patients, it's being partners in their healthcare decision, really understanding where things are in the process for prior authorization, having the ability to better adhere to your care plan because in a blue sky scenario, if that prior authorization can happen while you're sitting with the doctor, you know you're good to go, everything's approved as the doctor wants, and you can walk out the door with your care plan, know you're ready to go. It can mean reductions in care delays. So you're getting that prior authorization quickly and can quickly move into your care plan. And of course, care delays can mean cost and complications, and so therefore it can reduce those costs with timely care. For providers, the real hope, as Stephen noted, is reducing that burden by having an automated process that is now quite manual, having clinical decisions informed by what the patient can afford to have done and what can be covered by their plan. Incorporating the process into the workflow, making sure it's just part of the provider's workflow, having that transparency, reducing that back and forth and extra work to get a prior authorization done. And for payers, again, reducing that burden, automating that process, and reducing effort and cost. And again, one of the things that we've seen repeatedly is that one of the number one expenses and challenges is having to put forth or field prior authorization requests that weren't needed, but without having a really easy way to know that out of an abundance of caution and to make sure patients get the care they get submitted. An automated process leveraging the Da Vinci IGs can help reduce that. So we have this very strong foundation regarding the regulations, and we have some good things that one hopes comes from this regulatory background. So with that, we can talk a little bit more about what this all really means from a technical implementation perspective. So for that, I'll pass things over to Lloyd.
Thanks, Denise. Happy to be with you here today. So let's drill down into what's behind all of these acronyms. And HL7 loves acronyms. You'll find them all over the place. But we've got 4 separate implementation guides, 3 primary ones, and then a additional implementation guide that we use a tiny piece of. And all of them are designed to play together. They can be implemented separately, but the general expectation and hope is that both provider side and payer side support all of the guides, because when you do that, they really build on top of each other and sort of support the full process end to end. And we're going to go through each one of these in sequence and talk a little bit more about what each of them does. Next slide. So we're going to start out with coverage requirements discovery. This essentially functions as a decision support tool. So as a user, a clinician, administrative person, whomever, is performing their regular business function, ordering, booking appointments, dispatching orders, admitting patients, whatever it might be, in the background, a small package of information goes out from the EHR or whatever client system is being used to the payer that says, hey, here's what's going on clinically or business-wise. Do you have anything useful to share? And there's a number of different things that a payer might want to share, but our focus today is on the prior authorization side of things. And so what we're looking for and what the IGs set as a minimum expectation is that the payer is going to come back and say, this is covered, this is not covered, this needs prior auth, this doesn't need prior auth, this has additional documentation requirements, additional things that you might need to capture, and the information that needs to be captured should come from a clinician or from the patient themselves or back office staff. And with that, the clinician then has a sense of, should I possibly change what I'm doing, in much the same way as any other decision support that says, hey, this looks like it might be duplicate therapy, or it looks like there might be a contraindication here. The fact that this is not covered is an input into the clinical decision-making process. And they might say, well, it's too bad, it needs to happen, and I'll prepare the patient and make sure that they're okay and that it can still happen, but I'm not going to change what I'm ordering. Or they might change what they're ordering. And similarly, if there's prior authorization required, they might not choose to change what they're doing, but they will at least be prepared for the possibility that, well, I was going to send you to the imaging center downstairs and have it done right away, but if we're going to need prior auth, then maybe this is a tomorrow or next week kind of thing, as opposed to something that we can do immediately. And again, that may influence what the plan of care is. And so CRD is built on top of a technology called CDS hooks, which is a generic interface for clinical decision support of all kinds. And we just sort of plug into that and allow payers to be part of that, but we provide a bit more robust and automated information on the way back instead of just a little indication to the clinician of, here's a message to see. We actually provide computable information back to the EHR that says, presuming that you're going to bill as one of these codes, here's the answer, here's the reason why, and here's some pointers in terms of additional information that may be necessary. So that relevant information can be gathered right now if the clinician chooses to, rather than having the clinician poked this evening or tomorrow when the back office staff get into the, well, now we need to submit prior authorization, we need this, and we don't have the data yet, and trying to bring the clinician back into that same mindset of, who was that patient again and what was they trying to do? It gives them the ability to do that as part of their regular workflow. Next slide. One of the things that CRD brings to the table, this is not something that is the primary use case for CRD, but it's at least possible with CRD, is that as part of, here's what I'm doing, do you have anything useful to say? The payer can look at the information you provided, possibly also go in and gather additional information from the EHR using a security token that's provided, and say, well, based on what you're doing, it is going to need prior authorization. It's covered, but it will need prior auth. But I've looked at what my requirements are, and I've looked at the data that you have in the EHR, and it looks like you've ticked all of the boxes. So here's an authorization number. You don't actually have to do a formal prior authorization submission at all. You don't have to involve back office staff at all. It can happen automatically. This is not something we're necessarily expecting to happen the majority of the time. It'd be awesome if it could, but knowing for sure that all of the information is queryable won't necessarily always happen. Sometimes there may need to be special clinician attestations or whatever, and those won't already exist in the record. Or there may need to be human review on the payer side. In all of those circumstances, it might not necessarily fit, but we have that ability. Next slide. DTR is the interface that we use to gather the extra information. So if you have questions about past therapy or why is this happening or information like that, DTR allows a payer to say, here's the extra information that's needed and present that to the appropriate user. And that might be information needed for prior authorization, might be needed later for claims adjudication. It might be needed to just hold on to demonstrate that you're following appropriate use guidelines for subsequent audit. It might be information that needs to be submitted down to the performing provider so that they have it for billing purposes. And the questionnaires are standardized. So rather than going to different portals, the questions come to you and the EHR displays them with a standard interface. And the questionnaires come embedded with logic that can populate answers out of the EHR where that's possible, and also have logic that determines what order questions should be asked in, whether we can skip over certain ones based on the answers to previous questions, and sort of ease that flow of gathering information from the appropriate individual at the time that makes most sense in the workflow. Next slide. Again, it is possible with DTR, depending on how the questionnaires are managed. There's two different approaches. One of them does involve continuous back and forth between the EHR and payer saying, do you have more questions? Do you have more questions? And if you're using that, it is possible that once all the questions have been answered, the payer can now say, well, before I didn't know for sure whether prior authorization was going to be necessary or whether the criteria had been met. But now that you've answered everything, I do know the answers to that question. And would you like an authorization number because you've ticked all the boxes again? And the provider can say yes. And again, we can bypass that whole prior authorization process. Next slide. Last one is prior authorization support. This one is actually formally requesting a prior authorization, and it is aligned with the existing X12 278 standard, but it uses FHIR so that we have this consistent API experience through all of these different standards using the same sort of data representation mechanism, and now we're using it to actually formally submit prior auth. PATH supports an intermediary where you can have the FHIR data turned into X12 if that's how the payer prefers to do the processing. But with the exception, we now have the ability to pass FHIR directly from provider to payer without necessarily having X12 in the middle if that's what's desired, but there's still alignment with X12 because we'll need that on the billing side eventually. Next slide. So with PATH, we have the ability to submit an authorization. And the happy path is now that we've got the formal authorization request going in and a little bit more time for processing, the payer might come back and say, yep, here's your answer. Authorized or not authorized, here's a reason. This is the only circumstance where the payer is allowed to say no. You can't get rejected in CRD or DTR. But here you've got a formal request, and therefore we can, as a provider, or sorry, as a payer, say, no, you do not meet criteria, it's rejected. But in some cases, we won't be able to do that real time, and so we can send back a pending request. And in that circumstance, we have a notification mechanism where once the payer has done whatever processing they need, maybe they need to do manual review of an image or report or whatever. Once that's happened and the decision is updated, that the fact that that's available gets pushed to the provider. So they're not sort of, I wonder if there's anything, let me go check. It comes to you automatically as soon as it's available. And then there's also a mechanism in PATH to say, actually, after reading that report, even though you answered all the questions in DTR and gave them to me, and so therefore most of the time I have everything I needed, a human being had to look at the report and they have some more questions. And so we're going to ask for more data, and we have that ability, and that ties into our last IG, which is CDEX. Next slide. So CDEX is a guide that allows clinical information to flow to payers, and it supports a whole bunch of different workflows. But one piece of that implementation guide is an ability to take attachments, which we would get either as regular traditional document-based attachments, or alternatively, attachments created by using DTR. So PAS can say, hey, I need more information, and what I'd like you to do is invoke DTR again. Provider invokes DTR, answers the remaining questions, gets a little package of information, and that could be submitted as an attachment to the prior authorization request, and CDEX gives us a standardized mechanism for doing that. So that's the piece of CDEX that also is used as part of the burden reduction guides. Next slide. So as Denise was mentioning previously, there's a whole lot of benefits to using this collection of implementation guides. We have standardization across all EHRs and across all payers, so you don't have to have custom negotiations in order to have this data flow. We're moving much closer to real-time decision making, and certainly real-time information in front of clinicians and real ability to capture the relevant data and necessary data at the time that they're making decisions. We're trying to make data much more computable and have the workflow be consistent, so it doesn't matter what payer or payers a patient happens to have. The way that a clinician will end up interacting with the system will be the same across all of this. And of course, we need to meet the regulatory requirements. We've done our best to ensure that all of these guides do that, so that if you're worried about, well, how do I meet the regulatory requirement? If you comply with the guides, then you should be okay both now and hopefully into the future, based on the direction that the regulators have indicated that they're heading. But also that we meet all of the other regulations in terms of HIPAA rules, etc. So next slide. And this sort of repeats a lot of what Denise already said, but we provide benefits to patients because they get the decisions in terms of, is this going to actually be something that I'm going to have to pay for, or is it going to be covered, and therefore is it feasible for me? Providers don't have to worry about somebody coming and asking them later for more data because they've had the opportunity to gather all the relevant data at the initial decision point. And they've also come up with a plan of care that's going to work for the patient and the insurer. And so there isn't all of this back and forth. And of course, for payers, there's a whole lot less processing. They get all the information that they need the first time. And so it's a lot faster and easier for them as well. Less phone calls, less back and forth. Next slide. Obviously, the implementation guides cover a bunch of functionality. Not all of that is required by the current set of regulations. So the CMS regulations point to the implementation guides and recommend the use of the implementation guides, but does not require them. So technically, so long as you have a FHIR API for these things and you expose your rules using that API, you are good to go. However, the indication that we have from the regulators is that that flexibility will eventually go away because, of course, the regulators want there to be interoperability. And if everybody goes off and builds their own thing, we won't have that. So they didn't nail things down because they still wanted the guides to be able to evolve based on implementer feedback, because not everybody has rolled them out yet. But as we get more things rolled out and things are therefore more solid, I would expect that the flexibility will disappear somewhat. In terms of HTI-4, the requirement is that you actually support all three guides, although there isn't a compliance date set for that. But the only portion of CRD that is required is order sign. So they don't necessarily require support for the entire set of functionality the guide IG makes available. For for now, at least, they're only expecting a smaller portion of that. That said, all of the guides do define metrics that allow both sides, payers and providers, to track what's happening with their prior authorization, CRD, DTR pass implementations, and it is quite possible that there will be more expectations over time after everything gets up and running, and we'll start to see comparisons in terms of, are you as an EHR or as a payer doing well in terms of actually making things better for patients and providers. Next slide. So I'm going to keep talking, but we're going to transition now from what the heck is it that we're asking you to implement to, that's a whole lot of stuff. How the heck do I figure all of this out, and where do I get help? Next slide. So there are a bunch of resources that we have available, some of which hopefully you're already connected to. If you made it to this call or you found this recording, then it's pretty likely that you've at least connected with one of these, but we'll try to get you set up with more of them. So next slide. First one is listserv. Vinci operates under HL7, and we leverage their infrastructure. And if you go to the HL7 homepage, hl7.org, you might need to sign up for an account. That's free. You don't have to be a member to do that. But as soon as you've done that and they know who the heck you are, you can sign up for a listserv. So if you want to click, we'll highlight that little portion of the screen. So click there. And next slide, that will take you to a list of a whole whack of different work groups and organizations, sub-organizations within HL7. But one of those is the Da Vinci project. And we have a whole bunch of different listservs. That's where we send out notices for meetings like this one, but also all of our weekly calls, anything cool and exciting that's happening in terms of special meetings, major events, opening of ballots, or that sort of thing. So if you just want to keep track of the general high level and really important stuff, sign up for the listserv. It's not terribly high traffic, probably 1 or 2 messages a week, if that, for these lists, and just click on the ones that you're interested in. You can get summaries rather than receiving individual emails, so it's a rather low intensity way of keeping up with what's going on within the Da Vinci space. Next slide. The next way to get involved is to actually start engaging in the burden reduction project. And we have, again, leveraged HL7 infrastructure. They have a Confluence site, and we have spaces there for Da Vinci as a whole, as well as for the burden reduction implementation guides. And if you go into that area and look under the Da Vinci use cases, find burden reduction, within that you will see all of our different meetings. So we have meetings on Wednesdays and Thursdays and Fridays, because who doesn't want more meetings in their week? You don't need to come to all of them, but if you are in the guts of implementation, you may want to have somebody from your organization coming to most of them. That's where we actually work through questions from implementers, look at proposed changes to the specification, decide what we're going to do, get things ready for our next publication, etc. If you want to wade through all of our past minutes to see the fun discussions that we've had, you can do that there, but you'll also find the coordinates there to come and join our calls. Next slide. However, that's only a few times a week. And sometimes you have a question now and you'd kind of like an answer now. And so if you want more immediate responses, or just want back and forth discussion that isn't necessarily constrained to a 1-hour time block once a week, we leverage the HL7 tool of Zulip, also known as chat.fire.org. And that's also free. You'll need to sign up if you want to be able to post anything. If you just want to read, you can do that without signing up at all. And if we can just click and highlight the magic little button, uh, there's a tiny little plus sign, which is really innocuous. People have trouble finding it. When you first come into chat.fire.org, you'll only have 3 or 4 topics that are there by default. And for some reason, not everybody in the world thinks that Da Vinci is the most important thing, and Da Vinci is not one of those 3 or 4 topics. So if you want Da Vinci, click on that little plus thing and type Vinci, because that's a pretty good filter to find Da Vinci stuff. And you will see all of the different Da Vinci related topics, and then you can sign up for burden reduction as a whole, and CRD and DTR and CDEX and maybe HREX, which is a foundation for everything we do and pass. And that's where our continuous discussions happen. So if you have a question, you can ask there, and don't promise you an answer within an hour, but odds are really good that you'll have an answer within a day, because most of the IG authors are on there a lot of the time. Next slide. Sometimes people want to submit proposals for change because they see something in the specification that they think is missing, or they think is broken, or they think they have a better idea. And so for all of our specifications, CRD, DTR, PASS, CDEX, one of the links at the top of those specification pages is support. And if you click on that, you should see 2 links. One is the specification dashboard, which gives you a view of all of the current set of JIRA issues, ballot feedback, etc. And the other is the propose a change link. You do need to sign up for an HL7 ID in order to be able to submit change requests. It helps keep down the Viagra salespeople. Not that there's anything wrong with that. But you do not, again, have to be a member in order to suggest changes. And you also don't need to be a member in order to take a look at what changes other people have suggested or comment on them. And so if you're looking at how are the standards evolving or likely to evolve, that's a good way to keep up on what's happening there. Next slide. Last but not least, we have prepared a whole lot of educational material related to all of the burden reduction implementation guides. A lot of that material was prepared in conjunction with an education event that we held last April. But that material is still available through HL7. We don't yet, for some reason, have the recordings of the actual event live on HL7. We're in the process of figuring out why that didn't happen, because we thought it was supposed to, but that will be up there soon. And so that is also an excellent source of, hey, I didn't know about this Da Vinci stuff, but apparently I need to. So how do I get up to speed? There's 40 some hours of content that you can go through, and it's pretty good stuff. So that may also be helpful to you. Next slide. So that's enough of me talking. I'd now like to turn you over to Dr. Viet Nguyen, who is Da Vinci's project technical director.
Thanks a lot, Lloyd. And I'll reiterate, like, there are individuals like Lloyd who answer Zulip questions at 1 a.m. sometimes. I've seen it happen, so it's a really great way to engage. So with my section, I just want to elaborate a little bit more on some of the educational opportunities. We recognize that individuals and organizations are on a journey from, well, hopefully beyond what is FIRE all the way to implementing in production these prior authorization implementation guides. And along the way, we want to help you. From beginning all the way to what Lloyd talked about, engaging in the conversations with others in the Da Vinci community and helping us to improve our standards. So in terms of educational opportunities, if you go to the HL7 homepage and you click training, you'll see that there's a number of different options for training. We recognize that doing in-person training is difficult to scale and it's difficult to schedule for individuals. So we have lots of individual training courses that you can take to learn about fire, as well as the burden reduction implementation guides that I'll elaborate where Lloyd had just started. So you can find this training from the homepage, and I would encourage you to take a look at these different offerings and see which ones work best for your individual needs as well as your organizational needs. I'm just going to highlight a few. So on the next slide, Lloyd mentioned that we put together the Vinci as well as in conjunction with the Education Council at HL7, 3 courses. It was this recognition that we cover a lot of the broad overview and value of IGs when we do sessions like this, and I think that's really important for those of you who are business analysts or having to write documents to get funding to implement these technologies. But we also know that there are lots of developers who have to develop their expertise with fire. So we developed 3 courses that are available at the link at the bottom. And on the next slide, I'll highlight what's in these courses. And when you look at it, you'll see that there's actually a ton of material that we cover. And we really looked to cover this content at the developer level so that you understand these core fire technologies in the first set of classes that then are used by our implementation guides. So once you understand these concepts, you take the second course, and we talk more in depth about how they're used in the implementation guides. And then for prior authorization, as well as the payer data exchange, there's I think we added 55 hours of content, but we really believe that this content, once you absorb it all and you hear it 2, 3, 4, 5 times, then when you start to engage the Da Vinci calls in the community, you'll be much better prepared to listen to what's happening and then ultimately contribute to the work of the community. So we encourage you to take a look at these courses and see if they fit for your needs. So next slide. So along with that, we have virtual training events. One that is very popular for those getting into fire is the Fire Fundamentals course, which is both live and have homework that the students do, and it's taught by our fire educators. And we have one starting up on September 4th. So take a look at that. But they are trying to do a hybrid version for those who that model works well for. So next slide. I'm going to elaborate a little bit more from what Lloyd had described around our Confluence pages. This is the landing page, confluence.hl7.org. It's bookmarked on mine because I probably visit 2 or 3 dozen times a day. You can request an account. You'll see there's a little link there in the center lower part. It's free. It allows you to then view content, post comments, things like that. So we encourage you to get an HL7 account so that you can access all this information. But along with Da Vinci information, on the next slide, we have information about our work groups. So if you're familiar with conversations around implementation guides, they're sponsored by the various HL7 work groups who have the responsibility to oversee the quality and the content of the implementation guides as laid out by our ANSI accredited standards development processes. So not only can you visit the work groups, we have links to the various fire accelerators, and we try to do collaboration with them. I know that Codex is working with our burden reduction implementation guides and their community around oncology. So there's opportunities to engage in other areas of fire as well. On the next slide. We have a link on the left navigation of our Confluence page, a link to implementer support. What we've tried to do is to gather as much as we can resources for the implementers, all the way from learning about fire to working with our reference implementations, and ultimately, in a minute, we'll talk about doing pilots. So take a look at that page, along with the next slide, the page that I encourage folks to bookmark and to share, which is our implementation guide dashboard. It is a one-stop shop to find the implementation guide links, the project pages that we use for the work groups, so a little bit of information around future enhances, the status of guides, and links to the reference implementation. So we have a lot of information packed into that grid that will help you hopefully be able to navigate through our guides and see how the work of Da Vinci coincides very much with the work that we do in standards development in HL7 writ large. So next slide. I want to highlight something we've introduced over the past year or so, and Da Vinci has been sponsoring the creation and elaboration of what we call the Fire Foundry. So it's at foundry.hl7.org. If you type into the search bar or click that link on the left that has badges for Da Vinci, you'll see all of our reference implementations. Reference implementations have an important role in implementation guide development as we test fire profiles and fire operations to make sure that they work and that they comply with the constructs of fire, and where we have to add new profiles or we add new operations that they work. And so once we get to the point that we have a balloted implementation guide, we like to match it with a reference implementation, because it's one thing to read an implementation guide, but it's also helpful to see what it might look in an application. We recognize that we as HL7 and Da Vinci, we don't have claim systems or utilization management systems. So we sometimes have to stub those operations, but it helps at least for you to see what could be envisioned in an implementation. And something we recently introduced for those of you who are developers is the burden reduction bundle. It's not highlighted here, but if you type that in, we've been working with the reference implementation developers for CRD, DTR, and PAS, and we're able to link up each of those reference implementations so that a user can have a seamless experience from entering a code all the way into PAS. And then we've made it possible for you to download that reference implementation package. And as a developer, you could execute I think it's a Docker Compose file that would download all the components so you would have it on your desktop and be able to see how those operations and data are exchanged. So we encourage you to take a look at that, and then join us at the Connectathons, where we use the reference implementations as well as implementations from our members and the community to test out our implementation guides. Next slide. So with that, I'd like to re-invite back Stephen to tell us more about the Clinical Advisory Council's recommendations. That group really provides an important clinical provider voice to the work we do in Da Vinci.
Thanks, Jet. I appreciate it. So just for those that are maybe not familiar with the council, before I get into the kind of the recommendations, so this is a group of about 12 clinicians. I co-chair it with Ed Hugh from Sutter Health, and we have physicians in the ambulatory, in the primary care, in the hospital space. We have pharmacists. We have nursing representation on the council. And Da Vinci saw that there was a lot of clinicians that were providing feedback into the individual IGs and the work groups, but there really wasn't a group that was trying to look at Da Vinci as a whole and kind of strategically thinking about how's the clinician's kind of perspective and voice fit into that process. And that's why they created the Clinical Advisory Council. And I have the privilege to sit on the steering committee as a non-voting member, along with my co-chair Ed. So they were able to give feedback in real time to the steering committee from that clinician perspective. So if we go to the next slide, two important works that came out of the council very recently. The first is this notion of kind of insights on kind of adopting IGs. So, as clinicians, we're like chomping at the bit to get these things into production to see the value in practice. And we were trying to figure out well, what's keeping provider organizations from adopting these IGs? So we brought in a couple of folks that were, the innovators and early adopters of these IGs and had a conversation and talked about them on kind of best practices and barriers and opportunities. And then we brought together the council and had a couple of detailed conversations to flesh it out. And what we end up doing is creating a document that lays out what we think are some of the high level barriers to limit provider organizations from adopting these types of IGs, either just to do real world testing or to start to put them into production environments. And then there's another whole section in that document that talks about opportunities. And those opportunities are not limited to just what Da Vinci would be able to do, but it was really trying to look at kind of the community at large. So there's a lot of things there that Da Vinci is looking at and the steering committee has already started to think about. And they took some of our insights and brought it into some of that education stuff that Viet talked about. One of the things I really liked about the education stuff is they had different tracks for kind of the business folks and technical folks. So they were able to leverage some of our work to help them in that kind of business side. So that's the first one. So I encourage you to go in and take a look at that and seeing either understand those barriers before you dive into these IGs if you've not done that yet, or if you're in the community and how are ways that you might be able to help us drive acceleration, look at those opportunities. And the other one is this statement on prior authorization. And there's been some recent conversations around kind of, well, what's the full scope of the IGs? Should they still stay where they're at with being kind of real time and have that clinician interface into the workflow? Or should they be streamlined for easier adoption and really focus on more of the back office and not have the requirements of some of the real time stuff? And we just wanted to provide a clinical voice on why we think that real time and having that clinician in the loop process is really important. And again, as I mentioned in my earlier kind of comments at the top of the hour today, we understand that requires a lot more work, especially outside of the IG itself, but inside the EMR and the payer systems to support that work. But we think it's important, and we think it's probably as important to get it right and maybe delay things than to get something that really doesn't get to that end goal that I talked about of something that's clinically cost effective, timely, with low burden on providers and payers and patients to support this. It probably makes much more sense to get it right and maybe delay things a little bit if we need to do that. So that's what that statement talks about, knowing that the ballot is coming up here quite shortly. So I encourage you to take a look at those two resources. So if we go to the next slide, and I think I'm going to turn it back over again to my colleague once more, Denise, to talk a little bit more about kind of what's happening on implementation and some of our metrics in Da Vinci. So take it away again.
Thank you, Stephen. So before we get to some Q&A and hear from you, we wanted to just talk a little bit about where we are in terms of implementation and metrics from the IG side versus metrics from the regulatory side. So we talked a little bit about the metrics, specifically the metrics within the CMS interoperability and prior authorization final rule 0057. And just a quick note on those, because you will notice that reporting is required prior to the APIs being required. So the first metrics need to be reported for essentially data that came in 2025 and then reported in March 2026. And obviously the API is not required to be live until 2027, but those initial metrics provide a baseline. So that's the thought process there, just as a FYI. The IGs, however, were developed each with a section to facilitate reporting data to CMS and state agencies in an automated fashion where it's possible. And to really help folks measure the specific transactions that each of the IGs is facilitating. And so currently in the IGs and in the balloted versions, you'll see metrics listed as should or may. But in each of the three IGs, as Lloyd noted, there are metrics suggested for each. And so we've got the links here on the slides, and of course you'll get the slides to the specific metrics pages for each of the three IGs. But the idea here is that if you are implementing the IGs, then you essentially have the tools to also collect these metrics, and these metrics can then help also some of the reporting that's required ultimately at the federal level, but at the state levels as well. And it can help you also understand your rate of investment, how things are going, the value of leveraging these IGs. And so there's a whole host of metrics across the three IGs, but there are things like for coverage requirements discovery, the percent that were executed in under 5 seconds, which would be compliance with the IG. For documentation, templates, and rules, you'll see something like percents of questions auto-populated, which helps you see sort of how much of that information is in a very automated way coming to you on your first try. And then for prior authorization support metrics, it's things like the percent of PAS submissions returning a final result on initial submission for any item and all items. So ultimately, your successful full prior authorization electronically using the FHIR API. And so these are the kinds of things that are built into the IGs with lots of great information about how to, in fact, calculate these metrics, leveraging the IGs and the data there. So I think it's really valuable as we're thinking about where we are in implementation, where we're going in implementation, and how to measure the value of the IGs is the thinking about metrics, which is actually one of the reasons that we have been convening a Da Vinci prior authorization implementers group. It is open to both Da Vinci members and non-Da Vinci members. It's for everyone who is actively working toward or actively in production with a prior authorization solution leveraging one or more of the IGs that we've been talking about today. And so we have a link here to a Confluence page for this group. We meet monthly. The next meeting was moved due to the upcoming holidays. So instead of the first Monday, it'll be on the second Monday of the month, September 8th. And all the information about that call and that group, and also some information about where implementers are with their solutions development, testing, production is also included on that page. And one of the things we're really looking forward to with that group is not only understanding sort of the good, the bad, the ugly of how things are going with implementation and learning from each other, but also measuring how things are going. So we have that sort of real world data to understand where we are as a community with implementing these IGs. So with that, I'll hand it back to you, Alex.
Thanks so very much, Denise. Appreciate that. We do have a couple questions. So I think the first one I want to ask is related to some comments that Lloyd made. So if Lloyd, you want to come back on screen, that would be great. Because we have a question around CDEX. And curious if you can address how consent interplays with CDEX. So the question is, does or could CDEX require consent?
And the answer is it's complicated. And the portion of CDEX that we're talking about today, which is the portion that is used for burden reduction, is just a mechanism of submitting information as a claims attachment in much the same way as an attachment might have been attached to the original prior authorization request. And so all of the expectations around consent for submitting a prior authorization request to a payer are the same whether you're sending that information using CRD, DTR, PASS, or CDEX. So if your organization needs consent today to do any of those processes, that would still happen. In most circumstances, there's sort of an implicit, if you're giving us your insurer's card and saying, please bill them, there's certain information that needs to flow in order to have that happen. CDEX also lets you share information in other circumstances, and the consent requirements might be different there.
Yeah, I kind of think of this as the treatment, payment, and operations part of the exchange. So I suspect Denise might want to weigh in there, but Stephen, you're ready.
Yeah, and if you just teed the point that I want to make up too on the TPO. That's one thing. So you have consent from the patient perspective, but you also have consent to have the payer be able to access the EMR data. And one of the things that we talked about in the CAC is underneath HIPAA, you have all three of those TPO. But some of our docs are a little bit nervous, like, okay, well, you could use it for treatment and payment, but operations, are you going to start to aggregate this for network stuff and other things like that? So yeah, and I think there's going to be a further conversation to say, either try to define the consent to the point that you can get in and look at it anytime you want to, because I feel comfortable that you are not going to use it in a way that I don't want you to do it, versus, oh, I'm going to be really hesitant to let you get access to my EMR because I have those concerns. I don't have that trust ability to build up on that. So that's something that we've been talking about. We don't have any answers, but it is something the CAC has had conversations about. Thanks.
Well, and I think some of the prefetch and the rule, like the predefined rules and what data is going to come in and out of systems and be asked for, can help foster that trust because you actually have a pretty good audit trail. Not sure if Lloyd or others might want to comment on that aspect.
Yeah, I mean, there's specific requirements in CRD that says that the information that you access through CRD can only be used to return the CRD response and for audit purposes. So it's not allowed to be used for other kinds of things. I mean, in terms of if you submit a prior authorization uh, with attachments, I would expect that there would be similar rules around how that information can and can't be used, but that's not my area of expertise.
So anybody have any further comments on the consent and CRD or CDEX?
I would say that provider organizations who are on the call or listening to the recording, it'll be really important for you to work with your IT shop to understand your EHR and your information systems, because some EHRs, as I've learned, are very granular about what permissions they allow with respect to FHIR, all the way down to the resource level, and others may be more permissive. So understanding what your EHR permits, or technically, it will be really important as part of the implementation.
All right, so we had another question, and I'm not sure. I think this is related to a segment from Lloyd, but might be Denise. I'm not sure. The
I think
question,
it was Denise, actually.
all right, does the third 0057 metric dependent on EHR submitting the PA request?
So essentially, this goes back to the metrics in 0057, again, being required prior to any of the APIs being required. So again, the metrics have to be reported in March 2026 based on prior authorizations that occurred in 2025, and you're not required to leverage the API until 2027. But really, again, it's that baseline. And ultimately, this is meant to cover all PA requests. And it's to understand what that sort of baseline is. And so that's the understanding there regarding the PA requirements or the metrics that are coming up in March 2026.
Thank you, Denise. One of the things that you also mentioned earlier uh, when we're talking about the signals coming out of the federal landscape and also the state landscape, it embodies this concept of a movement to really fix prior authorization. And we want to reduce pajama time and provider burden. We want to promote patient transparency and visibility into services and financial liabilities. And that we're seeing this shift with the regulatory landscape wanting to be very selective on when they actually release a regulation. But we're seeing this other activities related to pledges happening. And there's a lot of signaling that we've been seeing that it's time for industry to lean more actively into driving standards development and declaring when they're ready for being established as more of a regulatory floor that's put into place. And we're seeing this seesaw between ASTP and CMS side of the house kind of leveraging their capabilities for sending signals and motivating us all towards this modern set of tools and capabilities that really get to better experiences, outcomes. And I think we've showcased today a lot of opportunities for workforce capabilities to be enhanced. But I'm curious if y'all had one thing you could ask for that would demonstrate the role of industry leaning forward and stepping up to drive the standards on which we compete and more effectively deliver services, what would it be? What would you want to see industry do to come forward and really lead standards development work?
I'd be happy to jump in first, because I mean pledges are awesome, but action is where the money's at, and I think my action that I would love to see, and we've been pushing at the AAFP a lot, and we talk about in the CAC, is just real world testing. So we're not saying put these into your production. We're saying get out there, try them out, let us know that they work, where they don't work, and also make sure that we understand what the workflows need to be on the periphery of these IGs, right? Because there's still a fair amount of work that's going to have to be done that's not in the IG, but it's in the feature set on both sides of these applications. So how do we share those kind of best practice? So that would be my one thing, is get that real world testing out there so we can make sure these are great solutions for physicians and patients and payers.
I was about to say come to Connectathon, which is pretty much the same thing that Stephen just said, because Connectathons are the events where we do our testing within the community. So absolutely. And it's good for the standard in that the more that we try using the standard and try to actually get systems to talk to each other, the better the standard becomes, which is benefits everyone. But it also makes you more comfortable that you understand how this thing is supposed to work, makes it more real. And if there's gotchas in there, it's always better to find them sooner rather than later. And testing is a great way to do that.
All right.
Yeah.
Denise, you
And
want to go
if
next? I'll
I,
go last.
yeah, if I could, you opened up a can of worms here, Alex. We're all going to jump in. Um, so I think that and it all comes down to the same thing, right? It's engagement. Because as a regulator, you appreciate that you can move a lever. However, the beauty of the fire standards is that the ultimate users of the standards can define the standards in a way that's going to best work for them. So engage in the process, support and shape that process, get involved in the work groups, get involved in the testing, and remember the end users. And so as part of that real world testing, engage, the provider within their workflow, the patient in the receipt of the information, so that we appreciate sort of how is this working full circle, but really taking the opportunity to, in fact, define that which you are going to be required to use, because it's a fascinating opportunity. Yeah.
Yeah, so those of you who come to these presentations frequently will hear us say that interoperability is a team sport. We take that very seriously. It's not just about the developers implementing software code. It's about leadership, understanding the value of interoperability in this data from a strategic point of view. There's the compliance folks. They're the business owners of workflows, whether it be provider workflows or payer workflows. And then they're the developers. And so we really need to work as a team within an organization and with your vendor partners to really understand fire. I often say even executives need to understand a little bit of fire because they have to vet and sign contracts with vendors. And you want to be able to have intelligent conversations with them about how their products meet or don't meet regulations and compliance requirements, and for you to really know what you're getting from the technology. So thanks.
Great comments and thoughts. Definitely, I agree with everything you've said, but I also think executives and leaders need to allocate human resources and financial resources so people can get engaged, influence what's happening, make sure all of the pieces of the ecosystem can work together. So with that, we do have some final words. And I would like to turn it over to Viet and Stephen to bring it home for us today on why this is so important.
So briefly, from my standpoint as a implementation officer as well as a technical director, is get engaged now. It's not too late. At some point, it will be more stressful to your organization if you wait. So really start building your capabilities. Come join us in our use case calls and connectathons and work groups. Engage in Zulip. Really build your team and your internal resources to implement these guides so that you'll be ready in January 2027, which will be sooner than we all think. Thank you, Stephen.
Yeah, thanks for that. And again, I just want to bring it back to the kind of the forest again, and kind of what we're trying to do here is really make it well so patients get the drugs and the procedures and the services that they need as timely as possible, but they also don't get them if they're not needed. And I just want to give two personal examples of both those scenarios. So I unfortunately had to go to Mayo to get a second opinion on some things, and they ordered a bunch of tests, and they do a great job of coordinating everything together. And my pair was like, hold on, you just had a PET scan. Do you really need another one? And they had a conversation, said, well, no, if you can authorize it really quick, if we do these other procedures and services and find out that clinically, yes, it's needed, let's do it. But because that took so long a time and I was traveling, they tried to bundle it all together, and my payer was great. And they said, yes, you do these things. Here's your number to the physician on our side. And if you need it, you need it. And unfortunately, I didn't need it because I couldn't take advantage of that. But that was a great one. They saved thousands of dollars. It didn't need to be done and put me through stuff that didn't need it to be done. But the other is I needed to have a drug, pancreatic enzyme, because I was having horrible symptoms and my malnutrition was bad. And it's an expensive drug. So I went to go fill it, and the pharmacist is like, that's $2,500 copay because it hadn't gotten prior auth. And luckily, I have means, so I did it. But most patients would have had to wait another week or so before the payer and my oncologist were able to work it out of saying, yeah, this is what it needed. And again, as soon as you got the data, everybody's like, well, yeah, it makes perfect sense why he's on that, even though it is expensive. So again, if we had these in place, both those situations would have been done same thing, except I wouldn't have that out of pocket, but they would have been done much faster and without any burden on those providers and without the stress on me to be able to do that. So again, I just want to lastly appreciate and thank everybody that's doing the hard work on getting these things together, and excited about the delight that you're going to be able to bring to thousands of physicians and patients once these are implemented and done well. So thank you so much, and thanks for the time today. I'll hand it back to you, Alex.
Really great remarks, and thank you for sharing your personal experiences. I know I have a number of my own personal prior authorization nightmares experiences, and I think that the movement is not only about industry working together, but it's about bringing the data at the right time for the right reason in the right securities to ensure that information flow and coordination can really help for the softest landing for the patients as they navigate their health issues. So we thank you for joining us for today's Community Roundtable. We look forward to seeing you at a future Community Roundtable. The next one is going to be September 24th, and we look forward to your participation. And in the meantime, I hope everyone stays well and advances 0057 compliance. Take care, everybody.
Thanks, everyone.